Good afternoon, everyone. I want to call to order the Committee of the Whole. Oh, Sheila now. There you go. Can we get a roll call?
Mr. Furman.
Present.
Dr. Giles gave notice she wasn't able to attend. Pastor Jones.
Present.
Dr. Guadalupe. Here. Ms. Woodruff. Dr. Hans gave notice. Ms. Newman. She said she's going to be a little late.
Okay.
Ms. Root. Here. Ms. May. Mr. Smith. Here. Mr. Cowan.
Present.
So you have a quorum for the Finance Committee, and we just need a couple more people to show up so we can start with Finance.
Start with Finance. Okay. All right, let's start with our first opportunity for public comment. Anyone online wishing to make a comment?
If you are online and wish to speak for public comment, please raise your hand at this time.
No one there? Okay. Anyone in the room who would wish to make a comment? There's also a second opportunity at the end of the meeting. Seeing no hands, let's move to item 1C. I need a motion for approval of the agenda.
So moved. Support.
There we go. We can do this by voice vote. All in favor?
Aye.
Aye. Any opposed? Motion carries. Okay, item 2, let's move to contractual obligations over $100,000. First one is Crown Castle Contract Amendment. Nasser. Trish. Somebody.
Again, is it Nasser?
It's Nasser, but I don't. Okay. Dana.
I'll wing through it. Okay, this is a board action request for Crown Castle Fiber. It's a fiber optic internet service for Troy and Pontiac locations. The original contract date is 5/1/2020 for $62,640. This contract is not, contract not to exceed amount of $190. I think this is for the amendment number 2. And so it's a 3-year contract. It looks like we had 2 renewals, two-year renewals or amendments, and this total cost of $190,000. And this is a 24-month contract extension for a fiber internet with Crown Castle. We will continue with the 2 GB or gigabytes at Troy and Pontiac to continue to support our organization. Prior breakdown price for amendment number 2 is $29,592 per year. So I hope I did it justice, but that's the board action in front of you.
Okay, thanks, Dana. Questions from the Finance Committee? Questions from other board members? Yep.
Is this something that we've done an RFP for recently or that we should complete soon?
Honestly, Ms. Root, I don't have that answer to that question, but I will follow up for you.
Okay, I was just curious. Thank you.
You're welcome.
Okay. Any other questions? I guess I just want to clarify. So the not to exceed the 190 would be the total for the 3 years. Am I reading that right?
That's how I'm reading it.
Okay. All right. And then, so at the full board meeting, we'll make sure we have the answer to Christine's question. Okay. All right. If no other questions, can I get a motion to move this forward to the full board?
So moved. Support.
Okay. Roll call, please.
Dr. Guadalupe.
Yes.
Pastor Jones.
Yes.
Mr. Furman.
Yes.
Mr. Young.
Yes.
Motion carries.
Okay. All right. Next, we'll move into the Finance Committee. We're in the Finance Committee. We'll get this out of order, Sheila. You confused me. So the financial update for March. Dana, do you want to make a few opening comments?
Absolutely, thank you. Good evening. I would like to introduce our new CFO in the consultant role, but no longer consultant role, is Richard Carpenter through the Raymond Group. So he has joined our team to work with our finance and budget team, so we welcome him here today. Thank you.
Okay. Have you,
Good evening. So we're going to walk through the March financials. And the first slide shows our revenue. This is a representation of the trend in our overall revenue, and you can see a slight and persistent decrease over time. The revenue that we're reporting is predominantly the money from MDHHS and the Medicaid dollars. You can see how those dollars are distributed between the different funding sources. And I think we've discussed this before, but just for clarity, the purpose of the graph is to show the trend, and it doesn't necessarily align dollar for dollar with the financials. The next slide is our eligibles, which really determines our capitation revenue. And you can see the trend there is relatively flat, but certainly improved from the prior year in terms of that downward trend. The next slide is our assets, the things that we quote-unquote own on the balance sheet. You can see the change since the end of the previous fiscal year over the last 6 months. Our cash and investments balance is up, and that's due in part to the fact that our receivables are down. We've gotten our money in a little bit faster than we did in the previous year. We're showing about $63.4 million in cash and investments and another $50 million in receivables. And a slight decrease in our capital asset net dollars because of predominantly depreciation. The next slide is an overview of our liabilities. Our vendor payables, which is predominantly our provider payments, the amounts that we owe our providers, is up about $20 million relative to the end of the fiscal year. We did receive money from the state, we owe less money to the state. We did pay off some money that was owed to the state, so that's the decrease there that you see of about $5 million in the next category. And then the next slide shows our net position, and you can see the decrease there from the end of the fiscal year from $28.9 million to about $18.2. Any questions on the balance sheet items? Okay, moving on. Next slide is an overview of our revenue. Our Medicaid revenue is up pretty meaningfully. And the rest of our revenue is relatively flat. So about $240 million through the first 6 months of the year for Medicaid. The next slide shows our expenses, and you can see a $31 million increase in our overall provider network expenses, and our other expenses remaining, again, relatively flat. I would point out the really relatively low amount dedicated to administration relative to the dollars that we're managing, and I know that we've talked about that before. And then the next slide is our net income, and you can see that our challenges continue. We've got about a $9.7 million deficit that we're contending with through the first 6 months of the year. And as we've noted in different conversations, that is a function of knowing that we are passing money through to the providers to provide the services to the people that we're dedicated to serving. The next slide is our overview of our providers, our top 15 providers, and this just graphically represents how those providers' dollars are distributed and services are distributed. The overview of the providers and some descriptions. And then the next slide is our statement of net position. And overall, this is just a numerical representation of some of the graphs that we've looked at already. A couple of things that I would highlight is that our current assets still exceed our current liabilities. The current ratio is above a 1-to-1, just slightly. So that's certainly a positive thing. And then on the statement of revenues, expenses, and change in net position, or the income statement in the for-profit world, that gives you an overview of the distribution of our revenue across the different funding sources, and also our operating expenses and the amounts, again, that we're paying out on the mental health and IDD service side, about $222 million overall, and the net position of deficit of $9.7 million. And that $9.7 million does take into account non-operating revenue, the dollars that we receive for our investments and rent and other things.
If I may, I'd like to kind of shift our focus from kind of looking backwards to looking forward a little bit into the fiscal year. So giving you some context of what is happening today and what we anticipate that might look like going forward. I don't know to what level of detail some of these things may have already been covered, so if obviously there are questions, please let me know. The PIHPs as a whole continue to analyze the DAB, what we call our DAB analysis. So the idea that individuals that are disabled, aged, and blind have been falling off of eligibility at a rate that was higher than anticipated, and that's been occurring since the end of the public health emergency and continues to today. So the number of eligibles are significantly below what was anticipated by the state of Michigan. So the PIHPs as a group, all 10 of us have looked at that. We're getting our preliminary findings. We're sending that to the state of Michigan to try to support a rate increase. The state does appear to be open to the idea of a rate increase and that one may be necessary, and the most recent indication is that that might be coming in June. So the hope is by the end of this month or early next month, we may have an indication of what a rate increase might look like and what, if any, revenue might be allocated and OCHN's portion of that. So we continue to be hopeful that the state is recognizing the issue. Again, that is not just impacting our county, but all the counties in the state of Michigan. And so we'll keep our eye on that and, of course, report back as quickly as we can. We continue to have conversations. Last week there was a webinar that I know many providers, including OCHN, was invited to related to the challenges at the federal level related to Medicaid funding. So we continue to keep our eyes on that. Right now we do not have enough detail to project or even anticipate what changes may be required. However, we are keeping our eyes open to what that might look like, and the state is very open to advocacy at the federal level of trying to make sure that we have the funding necessary to serve the individuals that we are responsible for. So keep our eyes on that and report back to the Finance Committee as well.
Thank you both. Questions from Finance Committee members?
I just got it's not so much a question as much as maybe a compliment and to thank the grant group. I noticed that we have grants of $4,995,663, which is really good, and I think that's a positive for us. in relation to being able to continue the services that we do. So to the Grants Department, thank you very much.
Any other questions? We'll switch to Policy Committee. Chris?
Yes, I have two questions. As a new kid on the block, can you explain to me the high vendor payables and what that means?
Yeah, so there's a couple of things going on as I'm aware of. I'll have to dive into the details, but I know that the vendor payables are going to be higher this year for a couple of reasons. Number one, we are calculating what we call an incurred but not reported. So at the end of every month, we take a look at the claims that we've seen come through the electronic medical record system, so our ODIN system. And then we look at a historical, we look back 12 months to see how much a typical amount of claims we would expect per month. And we trend that forward. So if as of this point in time, let's use an example of we only see 15 million in claims for let's say the month of March, but we would have anticipated 18 million, right? So we are accruing for the additional 3 million. So that would be in the vendor payable. Also, if we look at I'll use the CCBHC program as an example, if there are a certain number of T1040s that we are aware of through the end of March, and if our pre-funding is maybe below the amount that the T1040s would identify that we may owe, right, we would book an accrual for that as well. So that increased trend could be for a couple of different reasons, but those would be a couple examples of why they would trend higher than prior year.
Okay, I may need a course outside of this on that, but I thank you. And the second question I have, in your conversations with the state, we're seeing all sorts of problems with the Medicaid application, just asking for income up front. Most of the DAB population also has an asset test associated with it. So they're submitting this Medicaid application with just income information and then are getting lost when the asset information has to be processed. Are there any conversations with the state about potentially, addressing that particular issue, which I do think is causing a drop at the redeterminations?
Yeah, so my understanding is yes, there are ongoing conversations about addressing that issue specifically. A lot of our conversations at the CFO and the CEO level are with the state DHS office, right? And then there is the question about the impact on the local DHS offices and how the packets are being put together and submitted. While Dana may have her own additional comments on this, but my perception is that while MDHHS is sympathetic to our situation, they're not coming forward with any action items or any particular action plans to correct it. So unfortunately, I'm not really seeing the level of root cause analysis or movement on that issue from the state that I would like to see. I don't know if Dana's seeing anything differently.
No, it's the same, and when we find issues, it's really a one-to-one, like a one person, you find something and you send it. Although we've sent lists of people who have problems, we haven't had a systematic response to how they're going to be corrected.
Okay, any other questions from committee members?
I do have one other question, and probably because it's on everybody's mind and anybody has stock or whatever, but I noticed that the loss in the investment, and I'm looking, okay, I'm on page 13, down staring at the bottom.
Statement of revenues.
Investment income, right, and loss.
Yep.
All right, and projected, what is this, favorable, unfavorable, a little over $1,052,000, you see that?
Mm-hmm.
All right, and I don't know if there's something, I don't even think there is anything we can do about it, but I'm just wondering, what do I want to ask? Is there a way that we can sort of protect ourselves a little bit in relation to the loss? And I know that's difficult. The news today, some of the tariffs being released and the stock market up, but I'm just wondering, are we keeping our eye on that income as well? And that's the investment income?
Sure, the investment income is $317,000, and the interest expense is $89,000. We use an investment management company, and because of the nature of the organization that we are, there are parameters within which they are bound as far as how they invest our money. So our money is invested very conservatively, predominantly in fixed income instruments.
I mean, you can update us for the board meeting, but to me, as soon as I saw that and you brought it up, it's because we have less money that we're investing.
That's
We
absolutely.
we have a $9.7 million deficit because the state isn't reimbursing us. Well, we don't get any interest income on $9.7 million for 6 months. So I'm going to bet if you go through the numbers, you're probably going to find that's probably the case. So it's not because there's bad investments or, I mean, please check this, or we're not investing it properly. It's because we don't have this, what we projected to have for investment income was based on the principal, savings account, so to speak, that we have. Well, we've had to draw down on that savings account, unfortunately, because the state is not reimbursing us properly. And when you don't have the money to invest, you can't get interest income. So I think that's what we're going to find. So I'd ask you to double check that for the board meeting.
Thank you.
Yep.
I don't think we're having a loss on the investments in the sense of somebody invested the money in,
No.
bonds in some faraway place and nobody checked it,
The base of the investments is down significantly.
Yeah, right.
It's half of what it was the previous year, roughly.
Exactly. Right.
I was thinking of the Cayman Islands, maybe.
Oh, okay.
Because we're not subject to any tariffs that I know of yet.
Yeah, all right. One thing to look at, not an answer for today, but, maybe for the board meeting or maybe for the next committee meeting is, and we always do this, it's like comparing back to last year. And we're comparing 2 hurricanes, right? One now, one last year. I would also like to look, let's put like 23 on there, and maybe some of these categories, some trending, especially provider payables, right? I mean, that's going up, which theoretically means more money is being passed on for services, but let's take a look at that in perspective. Again, that's not to be answered today, but kind of some of those a few years back, so we can kind of take a look. Okay, does that make sense, Richard?
For the full board or for committee of the whole next month, how would you like that presented?
What I know you're kind of looking at everything, so if you can give a snapshot next week, great, and maybe go into a little bit more depth in, God, it's June already. Yeah, in June.
I know.
Whew. In June.
Okay.
Committee, okay? All right, any other questions? Okay, good. Sheila, this just is receive and file, right? We don't need a motion for that, or do we? Motion or no? No, all right. Okay, we're good. Thank you, gentlemen. Oh, no, wait, I'm sorry. Hang on, both of you. Fee for service. I had my note. That's right. That's why there's a squiggle over here. You threw me. Trish. Sheila, by the way, have you heard from Yvette? Is she going to make it at all? Okay, well, I'll be handing off to Christina here in a minute, so go ahead, Trish.
All right, hello. I'm here to give an operations update on our fee-for-service transition. So I will start with the next slide. So to give a little bit of background, this transition has been in the works for well over a year, since even before I joined in this position. And I'm going to give credit to literally everybody sitting behind me, because our team has worked tirelessly on this, budget and finance team, our IT team, operations, our provider network, SUD, our communications, our executive team, and so many more. We were looking at 12 unique service lines that are listed here, which is well over 1,200 unique code and modifier combinations. And I feel like that number continues to climb as we continue to get feedback on maybe some additional codes. So when we're looking at that many, and all of us, again, the Army behind me, combed through over 1,200 different codes and reviewed that. So Again, this is a transition away from our service models and away from cost reimbursement, which was in effect during the public health emergency. So next slide, please. So the big reason is really our purpose and our why of why we have transitioned. Switching to a fee-for-service model helps to promote efficiency, transparency, better align our financial, our finances. Really, under this model, providers are paid for the specific services that they deliver, which really encourages to focus on what is truly needed for those individuals served. So we have noticed that there was different rates among different providers for the same service. So that provider equity and that standardization of rates was really important to us so that we can ensure that one provider who is providing, say, for example, transportation, as you guys have heard before, is not receiving a lower rate than provider over here that's doing the same exact service. This is going to help improve our data and analytical capacity, improve our efficiency, also provides increased transparency into what we are paying. Fee-for-service directly ties the payment to the actual service provided. Each service is billed separately, which makes it easier for us to see exactly what care was given and how much that costs. And while this encourages that transparency and productivity and all of those things, we're really mindful that it could also lead to overutilization. So we are balancing that with quality oversight so that we can make sure that we are looking at all of that as well. Next slide. So our budget and finance team was tasked really as the lead, but really into many multidisciplinary teams to look at our rates. So this is kind of a bulleted point of the methodology that was used, looking at EQI data, looking at neighboring PIHPs, Milliman rates, really discussing with our subject matter experts on each of our teams that I mentioned before. Clinical was heavily involved about what was all involved in a certain service and what that would look like into a rate. Once rates were developed, we had a review process of a smaller fee-for-service work group, which meets every Friday morning, and I'm sure is the team's favorite meeting of the week, along with our chiefs doing a review and providing the rates to our providers, where they were then able to give feedback. So that's the stage we're in right now. We've gotten feedback from our providers. We are putting together sort of an FAQ that will be presented back and posted online that helps with some of the additional questions and intricacies that come along with those rates. And that is my very high level. Oh, that's kind of what I just mentioned, what the review process was. So our fee-for-service review, our provider review, which is where we're at now. We have had we've had weekly meetings with our providers on this transition. So Nasser leads our IT team, and they are meeting biweekly with the providers that use Odin, those who do not use Odin. Kim Flowers is leading our clinical and meeting with our the lead clinicians at the providers to ensure that those aspects are taken into account. Myself and Bernard are leading.
Can you explain what Odin is?
I'm sorry.
I'm reading Chris's mind. I remember my first year here, you guys would keep babbling about this Odin thing, and I thought, oh, good, Norse gods.
Chris, when you get through all of your trainings, you will be an expert in all these acronyms, I swear. Odin is our electronic health record, the name of it. If Odin stands for something, I don't know what that is, and I'm sure those behind me will tell me later. Okay. If it does stand for something.
All right, thank you.
And so then also Bernard and I are leading monthly meetings with the CEOs and the leadership of our core providers. Again, having that ongoing communication with them. Now that rates are out, I believe Rob and team will be meeting regularly with the CFOs, and again, to really have that connection with all of our providers to ensure that they're supported in this transition. And so I will open it up for questions. I know that was a pretty high-level, quick overview of where we are at. I will tell you that does not really sum up the amount of work that has gone into this. So like I mentioned, it was more than 1,200 different codes, the unbundling from the service models, which were put in place in 2019, I believe. just before the pandemic hit. And then when the public health emergency came, we went into cost reimbursement to make sure that the network was stable and that we were able to operate during that time. And so coming out of that and transitioning to this has been a huge team effort. So I really want to applaud our staff for all the work that they have done on this.
So was there a date specific when service models went in? Like you said, during the that's what I've always heard is, you don't have to, I mean, if you
I
find
joined
out.
in October 8th, 2018, actually, and I believe it had been started then. I can get a date for you and be able to get that.
Okay.
So.
All right.
And I will say, I guess, speaking of dates, July 1st is our date where we will be going fee-for-service and working with the providers up until that and then throughout so that 10-1 isn't a complete. Somebody knows
like
the
you
answer.
phoned a friend.
Yay, Jillian's here. She knows all.
These are not going to be exact dates, but we began the process in 2017.
Okay.
The first model that went to the first service models that were developed were the adult MI, followed by IDD and SED, and then the various direct service providers such as ABA, vocational, specialized res, and CLS, and that all happened in that 2017 through 2019 range.
What's that range?
Yep.
Okay,
Did that answer
good.
the question? Okay.
Yeah, perfectly. Thank you.
Yep.
All right, questions from others?
I will say for Chris, Jillian's our director of provider network team. She's also who I call our OCHN historian. So if there's any acronyms there, I'll fill you in when I get back to my seat.
She threw a couple in, but yeah. All right, Finance Committee, any questions? Seeing none, Policy Committee?
Just,
Oh, Chris, yes.
can you clarify, when you say service models, is that a capitated rate, or what were you referring to there?
I'll let Trish be the expert. Oh, here she comes again.
I'm hoping Jillian comes back.
Gee,
So,
wow,
yes.
hopped right up.
You might as well just stay.
All right. I'm sorry, the question was, were the service models a capitated rate?
Yeah.
Okay. Okay. So the service model is a little different depending on which service we're talking about. Most of them were based on a case rate. So as an example, one of the services that adult MI providers provide is called Assertive Community Treatment, or ACT. I'll try to be cognizant of the acronyms, sorry. And so for that particular service, there's an associated case rate, and I don't remember what it is. So it's not $100, but let's pretend it's $100. That $100 is paid per person as long as the service is provided in the month. So whether one service is provided or 100 ACT services. Excuse me. Does that make sense? And then there's other services that were already built in as fee-for-service. Therapy, for example, were fee-for-service. And then some services that were identified as at cost, like interpreter services, is one that stands out.
So when I think of fee-for-service, I think we're going back to the 1980s in some ways, but we're really returning to a system that is less than 10 years old.
So prior to the service models, we had a different contract structure, and I won't be able to give you a ton of historic detail, but they were called not to exceed contracts. We would give the provider $100,000. They were to serve everybody that was referred to them for that $100,000. If they went over it, that was their risk. If they went under that, they would owe us, the difference. That's a very simplistic explanation, I'm sure, but it was not to exceed contracts before we moved to those service models. And now we're moving to the fee-for-service across the board.
And I'll add, Chris, this aligns to what some of our other PIHP and partners are doing across. And again, it allows us that greater transparency into data and to see really kind of granular what is being paid for that specific service to that specific individual.
I can also add a little bit to that, because when we, like Jillian said, for transportation, I can bring up as an example, we
gave a provider a lump sum of money to fulfill the transportation services, and they contracted providers and paid them on a fee-for-service on whatever rate they negotiated with that provider. So we didn't provide the fee-for-service structure, our core providers did at that point. But now we're moving to a fee-for-service even with core providers.
Okay, hearing no other questions. Thank you for that. I'm sure we'll be hearing more every month.
Annual plan update?
Yep, but I'm turning it over to Christina to run this part
Policy
of the meeting.
management?
Yes.
All right. So it looks like we have 2 items on our policy management agenda, and we're starting with our 6-month fiscal year 25 annual plan update.
All right. So just a little clarification, I think we presented last month about our strategic plan and our fiscal year 26 plan. This is an update of where we're at for our current fiscal year, 6 months into it. So if we go, so we're currently on our current strategic plan, not to be confused with the one we'll be moving to. Next slide. So these are our current fiscal year 23 to 25 strategic focus areas. I believe we probably all know these very well because we go over these a lot. So we'll continue on to our next, and we'll go into administration and service delivery. So these are our 2 goals we have under this focus area. One is to increase the efficiency of pay structures and processes, which is standardizing our rates and moving to that fee-for-service model. And our second goal is to improve our administrative operations. So this is supported by 7 different objectives between multiple teams: budget and finance, claims, utilization management, executive leadership, and more than half of those goals are over 50% completion. And I believe in your packet you have a more detailed report too, so I can always get in a little bit more if you would like as well. Some of the mid-year highlights, we have done biweekly provider updates. We are doing quarterly provider meetings, both in person and virtual, to help promote open communication with our providers. We have standardized our rates. We have our fee-for-service coming up, and we are taking those feedback from our providers currently. Our financial software solution is to align internal departmental budgets, which is in progress. And our FMS and our SED services for our kids, which stands for serious emotional disturbance, were moved to a fee-for-service model earlier this year as well. Next up, we have integrated healthcare. So this goal is to expand our crisis continuum of care, which is supported by 4 different objectives within our clinical, our strategy team, our justice, and our crisis teams. This includes increasing behavioral health care accessibility, providing effective crisis de-escalation and crisis situations, and diverting individuals away from the justice system and into support, strengthening our community violence prevention and intervention strategies, and developing stronger relationships. So some of our mid-year highlights for this is our co-responders have expanded now to 16 communities, and we are constantly in discussion with new communities. I believe our core supervisor right now is at West Bloomfield City Council meeting presenting on that as well. We are working with the Greater Pontiac Coalition Timeout Team and Chance for Life, which came and presented, I believe, about 2 months ago here, on violence intervention. Our behavioral threat assessment and management policies and hiring is in progress, and we've actually secured a new grant. Frances and her team are on fire when it comes to grants. I believe we now have 3 different behavioral threat assessment grants to help support our initiative in preventing mass violence in our community. Our crisis team, led by our director, Kalia, is working with providers to improve data metrics, update policies, and really strengthen crisis offerings, as well as our clinical team under Adam participates in work groups with the Medicaid health plan. And next up, we have our partnerships, advocacy, and community outreach. So that goal is to really strengthen our strategic partnerships, which is supported by 4 different objectives across communications, training, and executive leadership. And some of our highlights here is that midway through the year, we are at 90 community events already. I heard they had a great turnout this past weekend for our veterans events. We've already hosted more than 170 different trainings, more than 220,000 website views, 2 new events, both the veterans and the SUD. I want to ask you to move to the next slide. We had our legislative breakfast, which a few of you were at in February, along with staff engagement and the legislative and coffee hours. And so also we partnered with the Forgotten Harvest and the Alliance Coalitions to do the Veteran and Military Family Drive-Through, which was in December, which was the first event of its kind. And with that, I'll turn it over to Frances to go for the next focus areas.
Good evening, everyone. So for the quality system of care, we have identified 6 objectives, and these are all led by OCHN Strategy, Access, Quality, SED, and Managed Care teams. It's very much a group effort, and with the 5 out of the 6 objectives are all in progress, and 4 are 50% or more complete by mid-year. Next slide. So some of the main highlights for this priority include the walk-in center, and which I believe that we presented on, and you've heard some information about already. This is our partnership with the Oakland County Health Division and our FQHC in Pontiac, Honor Community Health. And so that partnership is continuing strong and helping to divert people from higher levels of crisis. Our access team, led by Tradina Taylor, also worked with Oakland County Health Division to establish a clinician similar for these types of immediate care needs for behavioral health at the South Oakland Health Center in Southfield. So the idea is to expand these access points and get people connected with care from more points of access. And so the team had more than 17,000 calls as of the end of March and completed almost 3,600 screenings during that time as well. Also within the access team, I wanted to highlight the Mental Health School Navigator program. The team has, through FY25, taken 292 referrals from families and schools, and working directly with the schools and youth in the field, and have completed over 110 screenings there. And the team is finding that the screenings are particularly helpful connecting children with IDD to resources, and so that is kind of a previously unknown and unmet need in the community. So they're out in the field doing that work and getting people connected. Additionally, we successfully transitioned transportation services to more than 2,000 individuals, and that work continues with reviews of the services and looking to improve across all populations in the coming months. And I also wanted to note that the MAT services continue. The SUD team continues to work to establish the Women's Specialty Network. So that work is progressing. Next slide. So then for the staffing and retention priorities, so the goal to cultivate positive work environment that promotes staff recruitment and retainment, that one has 3 objectives, primarily under the Office of the COO and Human Resources team. All of the objectives are in progress, as the rest of the objectives are for this point in in the year. So a few highlights. Next slide, please. Include OCHN was named a top workplace by the Detroit Free Press for 2024. The team, the staff engagement activities included the Lions Theme all-staff meeting and other events within the community to promote behavioral health as a career choice and to try to continue to recruit despite the workforce challenges across the country. And OCHN also continued to promote the internal values, culture, and commitment to inclusion, diversity, equity, and accessibility, naming new committee co-chairs, working towards FY 25 through 27 objectives as well. Another notable resource job fair, October 11th, for recruitment. It was our first annual SUD and mental health resource and job expo at Oakland University. So I wanted to call that out. And next slide. And so I also wanted to thank Caitlin Toth, who is on the strategic initiatives team. She put together all of the slides, and I think they look really great, and as well as the report. So I wanted to give her that those props. And as we mentioned, all the objectives are still in progress as of the end of March, and we're going to continue progressing towards meeting the goals by the end of the year and addressing any barriers along the way.
Any questions from board members?
I'd just like to make not a question, but to thank you all for the efforts that you're doing with the veterans, because that's a big issue right now. I don't know if you can hear me, but that's a big issue right now. And the more that we can do to help them, whether it's in housing, food, what have you, please continue that. So it's good to see that we're taking part in it. Thank you.
I will give a shout out to our Veterans Navigator, Chuck McDonald, and our peer Veterans Navigator, Isaac Cortez. They do an amazing job on those things.
Thanks, Christina. And looking through the stats on the Access team, and with the there's two new centers in the last year, right? Working with Honor Health.
Yes, the Walk-In Center, so that is the partnership in Pontiac.
Right.
And then also through a partnership also with the county, but not necessarily including Honor. OCHN is also established in Southfield at the Public Health Department. Yeah.
Okay, all right. Thanks for clarifying, because I couldn't tell if they were. So and you don't have to answer this now if you don't have it, but the mix between like physical and mental or combined visits. I mean, do people come in for one and then we find out they have kind of both issues?
Yes, I can get the hard data for you because I'm sure Tridina's behind me, but the majority have been primarily physical health, but we also have to keep in mind that we have not really had a name to the clinic. We have not promoted it. The communications and marketing is still being developed, which we hope that will be out in the next couple of months. And so we have seen individuals come in primarily for, I think the top, when we were just there the other day, Dr. Posios and myself, pregnancy tests. A lot of those are the reasons somebody's coming in, and then they are screening. They're doing the PHQ-9 and that at every visit and really connecting. And they've just recently started making sure that the behavioral health clinician comes into every appointment, so they're really making that connection so that we can up our numbers. But we do anticipate once they have a name selected and some marketing, and we really do a large push. Right now, the majority of individuals we're seeing at the Honor location are connected to Honor already, or we're seeing them from the nurse on call with the health division. But there will be a much larger push as a behavioral health walk-in center.
And then.
Nope, they can't hear you online.
Okay, there you go.
For those online, I will say Tradina Taylor will be presenting at our study session.
Problem. I also have one question about Access, looking at the numbers for calls to Access, which is about 17,000, and then Access screenings completed is 3,500 or so. And I'm just curious if you have any significant feedback about the difference in those numbers. I know we do follow a no wrong door policy, correct? And sometimes I just worry as a social worker myself, people call and then maybe feel like they're not getting the services they need, or they're being turned somewhere else.
Absolutely.
And
This
not
is
getting-
also why we have all the directors here. So Tradina Taylor, our Director of Access.
Thank you.
So your question was the discrepancy in the calls that come through versus the individuals that screen?
Yeah.
So I always say we are the second number for customer service, if you will. So a lot of people call Access Line, our numbers blasted everywhere. So they call us asking questions, looking for people, things we may talk about here, who do I speak to about this, that, or another. I mean, everything, and I'll never forget it, such as, where's the local bingo hall? We get all kind of calls. So, and we talk to them. It's a call center, so we do assist individuals. So that's why the calls are so high, because Suzanne did a good job putting our number everywhere, but everyone that's calling does not amount to needing a higher level of care screening for services.
Okay, thank you so much. That
You're
makes
welcome.
sense. And that's a good problem to have, that our number is everywhere.
Yeah.
Thank you.
You're welcome.
Any other questions from board members? All right, thank you. Moving on to the next item on the policy agenda, we have our program compliance update with Marquita Massey.
Good evening. Marquita Massey, I'm the Deputy Chief Quality Officer here at OCHN. So I am here today to give you a quarterly compliance update. I'll be speaking to you about data that we've reported to the state for the first quarter of fiscal year 25. So the data that we report is due to the state 45 days after the end of the quarter. So we'll be reporting the second quarter data May the 15th. Here, the format of this presentation is similar to what you've seen in the past. It covers what a compliance program should have in place, the 7 elements, policies. You have to have code of conduct, compliance officer and oversight, training and education, a reporting hotline, monitoring and auditing, all these elements that they have to be in place for an effective compliance program to be operational. And we've spoken about this before, so I'm not going to spend too much time on this. One point that I do want to make on the next slide is our hotline reporting form that's currently on our website. We had a suggestion from a staff member about maybe naming this something a little more exciting and putting it in a more visible place. So we are in the process of doing that. So once that's done, our intent is to have it in a more prominent place on our website so folks can know that this is where they need to go to be able to report any type of compliance concern. So even so, with the format that we have now, we still are receiving a fair amount of hotline requests for investigations from our website. I think that once we probably make it a little more visible, we will likely get more activity there. You can move to the next slide. This slide is just a visual depiction of processes and practices that we have in place to meet the requirements of a compliance program. In the first row, over to the right, I spoke a little bit already about our compliance hotline. We also have a dedicated email box for any concerns to be reported. We have contract language in all of our contracts with our providers that explain what they have to have in place for an effective compliance program. And then for our internal staff, we also have a reporting link on our intranet site, and we do receive a fair amount of activity from that. Moving on down to the second row on the left, the first box there, we have many Power BI reports that have been created for us by our IT team that we can use to it assists us with our data mining activities and other types of issues that we may need to investigate and drill down to the causes of actions that have happened. We also have internal quarterly compliance meetings with all the senior management of OCHN where we discuss issues that have occurred during the quarter and problem solve on what we can do to try to remediate those kind of issues. And then on the last row in the right-hand corner, I want to speak a little bit about the requirement for the Board Regulatory Compliance Committee. This is new contract language starting fiscal year 25. I know that we spoke about this when we last met, but just as a reminder to the board, it's a requirement in our contract that we have a regulatory compliance committee where the board has an opportunity to really provide advice and guidance to OCHN on its compliance program. The committee must meet at least quarterly. Our intent is to use the board study sessions for those meetings because there's an opportunity to really delve deeper into data and reporting at those meetings. We're making an exception this month and covering this at the committee of the whole because the agenda for the study session was full. So we are covering that today at this meeting. So we can move to the next slide. Here on this slide is a summary of issues that have been reported for the first quarter of fiscal year 25. On the left-hand side of this slide would be activities that have been reported to the OIG, and on the right-hand side are internal types of issues that have been reported to our compliance committee. We don't really have like a wrong door, or we don't really want staff to question if something should be reported or not. We would prefer staff just to report it, and we'll parse it through and determine what actions need to be taken. But to cover what's on the right-hand side for OIG reporting, in quarter one we had one tip or grievance reported, and it was also resolved. In that same quarter, a tip or a grievance would be somebody maybe calls up to customer services and says, I have a concern about my case manager. I think she's billing for services and she's not providing those services. So that would be reported to OCHN to follow up on and investigate to determine if the allegation was valid or not. Also under this category is data mining. Data mining basically is looking at claims that have been billed and retrospectively using tools to determine if there are any improper billings. And every quarter we have 12 reports that we run. This quarter we did not have any findings from a result of those data mining activities. And then lastly in this category, we have audits. During this quarter, we had 14, we didn't have any initiated, we had 14 carryover audits from the previous quarter. We didn't, in terms of OIG referrals, we did receive 6 in that quarter, and then we also had some data reported to the OIG in response to our Medicaid claims verifications audits, where we identified some recoveries. Moving over to the right-hand side of this slide, internally, our staff continue to be very diligent about reporting when they make a goof or an oops, and maybe there has been a finding of misfiling of paperwork in an individual's file. They may find a document belonging to another individual in someone else's file. When that's found, it's reported. We would follow up with the core provider and have them investigate, and if necessary, require the provider to submit a corrective action plan. And then also in this quarter, we had several issues that were reported that fall into the category of provider performance concerns. A couple of examples that would fall into that category would be if a provider moved an individual without notifying OCHN. We also had a core provider that had loss of accreditation of their ACT program, where we are supportive of that provider continuing to provide ACT services because we need that service, but we are also monitoring that provider more closely to make sure that the program is moving towards ACT fidelity. And we were required to obtain approval from MDHHS in order to be able to continue with that.
Nice, good for you.
Okay.
How's family doing?
So we can move to the next slide. So I'm going to talk briefly about some other activity that we have going on here within OCHN. We still do see a couple of instances here and there of overlaps in services and also billing for services that have not actually been provided. When that actually happens, we do have to investigate, make a determination. Basically, we're conducting an audit, and we recoup as necessary. Also, some instances of units reported for billing exceeding allowable amounts. So we have reports that allow us to be able to identify these kind of issues. Our team has been very busy reviewing and approving authorizations over 4 hours per day, and then there's also been some requests to our team to review additional authorizations and approve additional authorizations. So when that happens, sometimes that requires us to dig a little deeper, and we find some other concerns there that need to be addressed. Also, the implementation of the electronic visit verification, that started back in September. The state rolled it out in a very slow process. It's not tied to billing yet, but it will be. We just don't know when. So our charge right now is to make sure that our providers are complying with that. What EVV is basically a check-in and a check-out system. So when services are being provided in an individual's home or in the community, the worker needs to basically clock in when they begin services, and they clock out when they end services. That can be done on the individual's landline in the person's home, but there's also a mobile app that the direct care worker can download, which allows them to clock in and clock out. So we are working to make sure we're ready to have our network ready to switch to EVV once it's tied to billing, which, as I said, we don't know when, but we want to be ready when that does happen. On the next slide, I just want to talk a little bit about some of the prevention controls that we have in place here. We do have checks in our EMR to be able to flag certain issues that are impossible. For example, there are services, all services are tied to certain procedure codes, and those are based on an individual's credentials. So if a person doesn't have specific credentials, they can't sign off on a document that if the services that they are reporting on is outside of the scope of their credentials. We also have controls that look at time overlaps. So you can't, an individual reporting services couldn't have start and stop times that overlap with each other. And there are also some procedure codes that require 2 signatures in order for the services to be billed. We also ensure that whenever a compliance issue is reported to us and we investigate and there are valid findings, we provide provider staff training and education and corrective action plans if needed. And then also with our staff here, if there are issues that arise, we require staff to complete training as well. Moving on to the next slide. Some of the examples of actions that we've taken are listed here. I mentioned training, so providing additional coaching and counseling to staff regarding the protection of PHI, which basically is the information from the individuals that we serve. We are also implementing enhanced supports audits. Enhanced supports are services that an individual may need that may require them to have 1-to-1 staffing or maybe 2-to-1 staffing. And then we also are in the practice of looking at a provider's history to see if they've had any previous issues being reported to us, and we have issued sanctions if a provider has had previous issues of compliance problems noted. So we can move to the next slide. I think that brings me to the end, so I can answer any questions that anybody may have. Pastor Jones?
Thank you. Thank you very much, Ms. Maskian. What a great report. With us moving to fee-for-services, do you anticipate more, and I'll call it checks and balances, in relation to proper billing for the services that we're giving? As you reported in this, there have been some where you had to go back and check they've overbilled or what have you. But are you anticipating, with our move toward more fee-for-services, that there will be an increase in the activity of your department?
Yes, we'll have to do that because we have to make sure that people are getting the services that they need, but we also want to make sure they're getting services that are medically necessary and not more than what's needed. So we do anticipate that.
Sarah?
Just a quick question. On the slide, I just want to read it right, the compliance activity reported, and there was OIG required reporting and then OCHN internal reporting. Is that OIG required reporting, does that have to be then sent to the state, or the state's just saying that has to be recorded to you all?
We have to submit a report every quarter to the state on any type of activity that falls into the scope that the OIG requires. So any misuse of Medicaid funding, we would report to the OIG quarterly.
Okay, thank you.
Go ahead, Chris.
Thank you. This is very, very helpful and useful. I have a quick question on the explanation of benefit statements. Why a random sample? Why is that not just standard practice?
Well, we serve like 29,000 people a year, so we can't issue an EOB for everyone that we serve, but we are required by the contract with the state that we at least do a review quarterly of EOBs and issue those out to persons served. So we do a random sample of persons served in a quarter to meet that requirement.
If somebody wanted an explanation of benefits, is that something they can get?
Sure, yes, they could do that. They would just call our customer services department, and we could generate that for them.
Any other questions? All right, thank you for the update, Ms. Massey.
Okay, thank you.
Am I turning the meeting back to you, Mr. Young?
Thank you. All right, we'll move on to item 5, other business. Communication outreach, Suzanne?
Good evening, everyone. Just the usual update. It's obviously a busy month. It's May. May is Mental Health Month, so we're engaged in a lot of different activities. Some of them are, you can see there are a number of trainings, as you heard earlier. We have done quite a few trainings already so far this year, and there are many coming up in the next month or two. So a number of trainings coming up. Already happened, as well as OCHN is, as you know, always invited to participate in a lot of community events and community outreach. So we've hosted a number of tables already this month, just providing OCHN services and supports information. So we'll go on to the next. One really quick thing I just wanted to mention too, the NatCon conference. We had a number of leadership and staff that attended the NatCon conference last week, and I'm sure gained a wealth of information to bring forward to the rest of us. So now we can move to the next slide. I think it was already mentioned that we held the annual Veterans event. This is our 3rd annual event. Actually held it for the first time here in this building. It was bustling, so there were quite a few activities going on for the event. We had almost 200 people that attended. We thought we probably had about 150 or so registered. We had quite a few walk-ins that day. We did some outreach and some advertising to get more people here, and it really worked out. So we had a lot of presentations, really enriching presentations from the Alzheimer's Association, as well as some training. We handed out some gun safety boxes, and we did some training for individuals before they received those gun safety boxes. We had the VA here to talk about benefits. We had the health division here to provide vaccines. We fed everybody, so it was face painting, balloons. It was lots of fun. So we had you'll see some photos from that at the end, as I usually share something of our events each month. Also wanted to mention there are a few conferences coming up. As you can see, those are noted on this slide, including APA, NAMI, and the Mackinac Policy Conference. And next slide, please. And then this just gives you a highlight of what we have coming up in June. Lots of trainings, as you can see, as well as we are hosting our annual community baby shower event at Welcome Baptist. So we're looking forward to that coming up the beginning of next month. Next slide, please. Also wanted to mention some of the press releases we have going out. Our May is Mental Health Month press release already went out, as well as lots of other activities for May is Mental Health Month. Obviously, it's on our website, our social media. We have our proclamations. We've received quite a few of those proclamations back of many of the cities and villages that have accepted those. So lots of different events. And as you can see, participating in a lot of community events that are happening throughout Oakland County and beyond. And then our advertising outreach is some ongoing advertising with our billboards, bus ads, radio, and television, theater. And then our conference room usage. But what I really wanted to share with you, the next slide, just a little recap from our Veterans event. As you can see, we had full room here as well as in our cafe. It was really just a great event. Tridina was our headliner. She welcomed us, and obviously our Veterans Navigator and our peer navigator were an integral part. I can't thank the communications team enough. They did a fabulous job kind of helping to coordinate. It was a great partnership. So looking forward to bigger and better next year. That's all I have.
Any questions? Pastor Jones.
Suzanne, just so I don't forget, for the youth event, children's event in June. The Zeta sorority, I want to make sure we contact them because they work a lot with their children for new parents. And I had a discussion with DTE. They have a special package that they put together. Inside that package is protection to stop kids from poking into the electrical outlets. And so I want to make sure that they get in contact to bring you a bunch of those. So if you would give me a call, we'll make sure that we cover that, but those two. And then the third piece is OSHA. She had some difficulty in contacting them for the $500 monthly help that they were giving for new parents. And so if there's a way that we can recontact them, that'd be good, especially for the June event that you have, because I think it would be a benefit for them. So there's the three things. If you would make note, and I'll try to remember as well. But I anticipate that that's going to be just a great event for the new parents and what have you. Thank you.
Thank you.
All right. I don't see any other lights on. Thank you, Suzanne.
Thank you so much.
All right. Wow, you guys saving the most interesting for last here. Item B, transportation update. Pastor Jones' favorite. As is, yeah.
Hello, so my name's Anna Nasser. I am the new transportation administrator. Originally it was going to be June with me, but Bernard so graciously stepped in, so I'm going to give you some updates. I first just wanted to make sure, this is my first time presenting at a COW meeting, Committee of the Whole, so I just wanted to make sure that I didn't want to assume anything, so I wanted to go back to why we brought transportation in-house. There were three main reasons. The first was to reduce administration layer by removing core providers, provide direct billing options, and to establish direct relationships with OCHN as the funder. And as I will show you in the next slide, I think most of those are well on its way of being accomplished. So, next slide. So, yep, figured that was going to happen. I brought my laptop because I'm not going to be able to read that. So we have a couple things to update. The first one is that as of January 2025, the transportation administrator was hired. That was me. And the managed care team was developed. So there's a team now supporting with all things transportation, which is great because as of October 1st of 2024, OCHN successfully brought in-house transportation for the IDD population. There has been a little bit of confusion over which who bills transportation separately and when is transportation still included in the service rate, because it was we brought it in-house by population, not by service, which is why we developed a transportation email, which has been very helpful. I've been able to quickly answer those questions, reassure providers who's billing under which code, and so we bring more providers in-house. Another thing that has been really helpful for providers to help with some of the confusion with this transition is the FAQ, which I developed an update for in February that is now on the OCHN transportation website. A lot of questions can be answered in the FAQ. And we also created, there was a dashboard, and then before I was hired, and then I have worked closely with the IT team to develop the dashboard so that we can watch over some of just the data in general. One of the things we were looking at is gaps around what cities aren't receiving transportation. It was a very quick visual, real-time data, real quick visual to see where transportation wasn't being covered. IT did a fabulous job. The map is amazing, and the things that you can see with that map and the data that it pulls is really cool. And with that, I was able to determine where we needed transportation so that we were able to put out an application to participate. That has been launched. We actually, like last week after I turned this in, got our first application in. So we're reviewing that. Applications will be closed as of June 13th, mainly so that we can review everything that we were requesting, make sure it's still the things we want to be requesting, review the applications that are in, and then, if necessary, we can reopen it. And then we also developed some transportation logs to standardize how transportation data was being collected and which routes, who was on which route, and how often they are being picked up and where they're going and everything. That officially launched May 1st after 2 training sessions. The training sessions insights are also found on the OCHN Transportation website. We recorded the final training. So that is all well on its way. And then lastly, I continue to, with that dashboard, manage and review data that is being collected every day. So next slide. So really the next steps, one, continue to analyze the daily transportation data that is coming in through the dashboard, review the applications for new transportation providers to be included, and then lastly, we do have a goal of opening or bringing in-house more programs, not just IDD, and we are working currently on achieving that. So yeah, next slide. I think it's just Q&A.
Questions? All right, I'll start. Actually, thank you for saying so clearly that it rolled out by population, not by service. I think that was a key message that should have been much louder on September 30th, October 1st. I wish Dr. Hans was here to hear that, because she and I probably got the brunt of families. So you talked about kind of the website and mapping. Can you talk for a minute? I know there's been dialogue with the county since the millage passed, but just in terms of working with SMART, NODA, WODA, OPC, any details on that, or is that still kind of a secondary wraparound service?
Are we contracting with them?
Yeah, well, let me be even more specific. As you get into the northern quarter or the western third of the county, things get pretty sparse. And I can even be more specific of example if you need it. But I mean, there's a millage, and then there's this. Both the county executive's office and we've talked about working together. My question is that kind of day-to-day happening, or is that still?
And I can field this if you want one. So transportation, we were working with them. Francis Carley and I met with them prior to coming in-house. Since then, I've been invited to an Oakland County work group with SMART, OPC. I transferred that over to Anna. There was a meeting last week because they want our input on transportation and how it affects our populations for service delivery. So with NODA, WODA, NODA is northern Oakland County,
Right.
WODA is western Oakland County, and then there's OPC, I believe, and then SMART, right?
Right.
So with the millage with that, now that they're being able to bring in the funding, we do contract with NODA. WODA invoices us when they do service delivery for our population. We don't contract with them per se, but they will invoice us at whatever that millage rate is. So there's not a direct contract with WODA, but NODA, I believe we do have a direct contract with and align our transportation services with them.
So is the end customer paying anything at the time of service, or is this all?
No.
Good. That's the core of the question. Okay.
Yep.
All right.
Yep. But we are continuing that dialogue with the public entities
Good.
and with third-party transportation, just to make sure that our network is open, because transportation is key to service delivery. So.
Right, and a lot of I'll give Smart credit for adding a lot more of the flex vans, but, you know, overall transportation, whether it's by the providers or by the county or by Smart, most of the fleet out there is
Right.
not exactly new. So the more sources we have, I think the better.
Right. One thing I would like to add, and this was with respect to NODA and WODA, because they are separate entities and they are not aligned with RPIHP, there were separate negotiations with each.
Okay.
And so they approached the provision of service for the IDD population differently.
Okay.
So that is why the alignment of one is contracted with us, one is not, is the way that those services currently are received.
Okay.
But it's anticipated that we will, over the course of the remainder of this fiscal year and then next year, be able to negotiate with them again once everyone understands the respective relationships.
Yeah, good. Okay. Yeah, I knew it wouldn't be easy, but I think it's important that we show this, you know, especially as we talk to the county about increased funding, we need to make sure at least a couple individuals are happy we're working together. Okay, other questions? Quiet. All right. You satisfied all the questions. Very good.
Thank you.
Thank you both. All right, moving on to item 6, our second opportunity for public comment. First, let's go online.
If you are online and wish to speak for public comment, please raise your hand at this time.
Seeing none. Okay, second opportunity for individuals in the room for public comment. Nope. All right, item 7, board member comments. I will start with Christina. Pastor Jones?
No comment.
Oh my, wow. We'll go all the way to Adam.
Yep, I'd just like to thank everyone for the engaging, as always, presentations. We had a lot of material to go through tonight, but it was all very worthwhile. And again, thank you to not only the staff, but also the administration team that puts all the presentations together. So thank you very much.
Chris?
I just want to thank all the directors and other individuals from OCHN who are here in person. It's so helpful as a new board member to see your faces and to get to know you, and I continue to be impressed with your work, so thank you.
Okay, Sarah?
Thank you to everyone who provided presentations tonight. Very helpful and appreciate the time and information. Thank you.
All right, Melchiah?
No comments.
All right, and I will echo the thanks. A lot of good discussion this evening, and we will stand adjourned. Thanks, everybody.